All right. Well, I appreciate everyone coming on for the webinar today. My name is Nick Jaworski. I'm the CEO of Circle Social, and we have the CEO of BB Health Tech, Keith Booher, here as well. I'm going to do the first half of the kind of presentation here, and then Keith will take over the second half. So he'll introduce himself a little bit more fully on his half of the presentation. So just a quick overview of the background that we're bringing to the table here so that you can understand like what we're looking at and why we're looking at KPIs as a really important metric for providers to know across departments. So Circle Social has about $2 billion worth of data specific to providers. And so when we work on the marketing end, when we work on the consulting end, we're very focused on KPIs, what's working within the provider, what's not working. And that's across departments, right? It's not just marketing. Marketing is obviously an important component, but it's also your clinical, it's your call center, it's your business development team, it's communications, operations, and financials overall. So I am going to speak mainly to a little bit of a 30,000 foot view on KPIs in terms of what creates a sustainable and healthy business operation for a provider, whether you're a nonprofit or a for-profit. It doesn't really matter. Your bottom line metrics are going to be the same. And then on top of that, I'll dive into admissions and marketing specifically, and then I'll let Keith take over and he'll do a deeper dive into billing and some of the related clinical indicators for that. So again, really appreciate everyone joining today. We'll jump in and get started. So just making sure we're all on the same page with what KPIs are. Obviously, they're quantifiable metrics about the performance of your business overall, about specific departments, about specific employees. And so you have to be able to create some kind of baseline to know, are you doing well or you're not doing well? And then on top of that, when you make changes or you put certain actions in place, are you able to move that needle, right? So that's really important. So what we really want to do when we're looking at these components is say, establish a baseline, and every single provider is going to be different. There is baselines that we have expectations, like when we go in a provider, we're looking at those, but we see variance across levels of care. We see variance across geographies and variance across the structure and the strengths and weaknesses of a particular organization. So a lot of the KPIs that we'll share with you today, we're going to give you what those KPIs are, but we're also going to give you some baseline metrics. And so just keep in mind that these are baseline metrics. It doesn't mean that it's exactly going to be right for your organization. The best thing that you can do is start tracking your own metrics and build your own baselines so that you're able to track your own performance improvement is kind of critical in these components. So 30,000 foot view, what are we looking at? What works? We've got kind of three legs of the stool for a successful provider. So we've got admissions, clinical, and revenue cycle management or billing components of it. And these are really just kind of three legs. So on the admissions side, you're looking at your cost per admission or cost per customer acquisition is sometimes how it's termed in the regular world, I guess. But cost per admission or patient admission is what we're looking at from purely admissions and a marketing standpoint. Now, there's a lot that goes under that, and we'll dig into it a little bit. But your cost per admission is going to critically determine how expensive it is for you to attract patients into the program. And if you're paying too much money, obviously, from an acquisition standpoint, whether that's digital marketing, traditional marketing, business development, alumni referrals, et cetera, your business is not going to be sustainable. And I would say that this is probably one of the number one areas where we see massive opportunities for improvement with the majority of providers, big and small. We've gone into large providers that are spending $15,000 on their digital admissions. And a lot of times they don't even know. That's why tracking is critical and accurate tracking. There are many opportunities to make mistakes in how you're tracking the setup. Are you tracking all calls? Are you tracking 30-second calls, 60-second calls? Are you tracking it per channel, or are you just tracking it in general? How is your call center connected to that? Are you looking at call center conversions? Are you looking at individual call rep conversions? Where does your business development fit into that mix? So very, very important to understand that there are all these different pieces to the admissions component, and they all have to be working together. But if they're not working together well, you can see just astronomical costs on that end. So it's something that's very, very important to keep under control. And again, I'll dive into some of the specifics in a bit here. On the clinical side, you got average length of stay is really, really important, right? So your average length of stay is determined by the clinical team as well as the billing team, right? Because your utilization review, your UR is pretty important as well. But you can't do UR unless your clinical team is providing good documentation and notes. So the average length of stay is a really, really important part to the financial stool of any provider in the SUD space, because if your patients are leaving early for any reason, or if they're just not stepping down appropriately is a big one as well. If you've got a longer continuum of care, if you've got multiple levels of care, you want to see 70% step down rates as a minimum from one level of care to the other. And if you're not seeing that, then you're losing out, obviously, on the patient's opportunity to bring revenue into the organization. But just as importantly, they're not getting the care that they need. So what you really want to see with patients is, we all know that the longer they're connected to care, the better their performance metrics are in terms of recovery, right? And so we want to make sure that they're connected, and the payers see that as really important. So I was just talking to Deb Nussbaum, who oversees Optum's SUD division yesterday, and she was very clear that if she's not seeing providers, when they look at in-network contract negotiations on who to speak with, if they're not seeing that patients are stepping down to other levels of care, it doesn't have to be within your organization. It can be to another provider that maybe provides that level of care if you don't, but they want to see that connection, because the payers know, based on the claims data, that if patients are continuing in their therapy and in their treatment, that they're much more likely to be successful, and that those are going to drive down costs for the payers. So they very closely monitor step-down metrics, and our providers actively connecting patients to care, double checking that they're getting there, or within their own continuum, are they being stepped down appropriately? And then on the revenue cycle management end, it's average daily reimbursement, right? So what are you getting reimbursed per level of care is critical, and that's that third leg of the stool. It's great if we've got patients coming in the door. It's great if they're staying through their clinically assessed length of stay. But if you're not getting paid appropriately for them, then that's a massive challenge, right? And so that really comes down to your billing team. And so when you're thinking about average daily reimbursement, it's not just what's in your contracted rate, right? It's your payer mix. And so how are you understanding which patients are coming in from policies that are able to work for you? And then on top of that, how are you looking at what they're actually collecting? So there's a patient responsibility component in there that Keith will talk about. And there's just this component around how many patients are actually you're getting reimbursed for those patients, because if your billing team is getting a lot of denials, right, that drives up your costs, or it drives down what you're actually able to collect. So those three pieces, your cost per admission, your average length of stay, and then finally your average daily reimbursement, are the three legs of the stool. So we'll do a deeper dive into admissions here, a little bit of marketing, and then I will kick that over to Keith. So these are part of the top 20 KPIs for SUD. We already talked about your bed occupancy rate, but obviously the census that you have in the facility is super important to sustainability and profitable financial operations. If you have 100 beds and you're only filling 50 of them, it's very, very hard to obviously make it a viable business. You got too many fixed costs a lot of the time to be able to make that work. So what you're really looking to do is get to that 70, 80% ADC, average daily census, across levels of care. And that's really going to help you be financially sustainable. So that comes down to all those components we're talking about. Average length of stay, cost per admission, these will factor in what your ADC ends up being. Length of stay we talked about. AMAs and readmissions are really important. What we're looking for is to keep AMAs under 10% whenever possible. And you drill that down as well, right? There's a difference between someone that AMAs in the first 7 days and someone that AMAs after 7 days. In the first 7 days, there's something around a mismatch in expectations or levels of care. Something was not communicated appropriately, or the initial experience on intake wasn't appropriate. And so that person decides that they need to leave right away. There's also issues around programming. If there's not enough structured programming in the evenings or weekends, that can lead to really high AMA rates in the first 7 days. If it's after that initial 7 days, it's almost always staffing issues. So for some reason, the staff is not building a rapport, whether it's behavioral health techs or the therapists or the counselors, they're not getting along with the patients, and that's leading to a higher AMA rate. Readmissions, you have to be careful with, right? So readmissions, a really good facility will only see about 10% readmissions in a given 12-month window. The reality is that most providers see 20% or higher. So you really want to look at your readmissions, and obviously it's helpful from a patient standpoint if you got patients coming back in, and it's good that they liked your care enough to come back. So there's some value there. But if you're having too many patients readmit, then you're definitely going to raise red flags with the payers. Most of the payers kind of have a step down window. So it's between 12 and 15% in the first 30, 60, 90 days. And so if they're seeing 12% of patients readmit anywhere, not just your facility, right, based on claims data, that's going to raise a red flag with the payers. If they're seeing 15% of your patients readmit within the first 90 days, that is going to raise a red flag with the payers. So you have to make sure that you're tracking some of these numbers. So are you providing effective clinical care based on national benchmarks? And if not, then you can make improvements so that you are making sure that patients are staying and completing the care that they need, but also that they're not relapsing or readmitting in a time frame that is below standard. So leads, VOB, and admits, that's a lot of what we focus on the marketing end, obviously. And you want to look at your conversion rates as well as your total costs. So when we're thinking about the leads, or the way that we usually refer to them at Circle Social is inquiries. An inquiry is your cost per form fill or your cost per call. You can also look at a cost per live chat, but a live chat is a very different kind of tool, and it operates under different metrics. Live chats tend to not be as high intent, where a call or a form fill are much higher intent. Really important with anything coming in from an inquiry, it has to be answered right away. So you need a system or a process in place where you're answering all the calls. If you're missing calls, you're missing admissions. Same thing with form fills. If a form fill comes in through the web and someone gets to it the next day, well, you might as well not even get to it because it's already gone. You need to be answering form fills immediately. Same thing with anything that comes in from live chat or Facebook messaging. If you don't have someone dedicated to answering these basically immediately, or at least in less than 5 minutes, they have really no efficacy. So it's really critical that if you have this system set up to receive these inquiries, you've got the same systems and talent set up to answer the inquiries. So from a VOB standpoint, let's break down Google Ads, because everyone is obsessed with Google Ads in the treatment space. When we're looking at Google Ads and call volume and admissions, your standard cost for a 60-second call, what we would consider a qualified inquiry, is around $150. So you have to look at how many calls do you need from a Google Ads campaign to then potentially convert. What's your call center team converting at? And then what does that cost you from an admission standpoint? So Google Ads is not a real great channel for high quality inquiries. It's just based on the way that people use Google. So what we'll see is the majority of those calls are Medicaid or no resource, because Medicaid and no resource are not paying anything, right? There is no risk to them. There's no cost to them. So they basically just Google it and then call down the screen. So when they call down the screen, they hit the ads first and they call the ads. So about 1 in 10 calls from a Google Ads campaign is going to be Medicaid or no resource, meaning that 1 in 10 calls is a VOB. And so if 1 in 10 calls is a VOB, that means that you're paying around $1,500 as a VOB cost. Now, again, that varies geographically, and there's other factors that go into it, but it's just a good baseline rate to really be thinking of. And then it depends on your conversion rate for the team or the insurances that you're in contract with, right? So if we look at most VOBs coming in, only about half of them have viable out-of-network benefits that someone might be able to work with if you have the out-of-network side of it. And so then your VOB cost is doubling, right? So for you to get an out-of-network VOB, it's a minimum of $3,000 usually from a Google Ads campaign. So then what does your team convert at? Most teams only convert at maybe 30%. That's a pretty good team if they're able to take a certified VOB and have that person come in as admission. So you have to kind of think through those numbers, right? It's going to cost me on the in-network side $1,500 to get a VOB. I'm only converting 1 in 3 of those at a 30% conversion rate. So I'm paying roughly $4,500 in admission. On our end, we've seen admissions come in as low as $1,800 for certain markets with really good call teams and really good marketing campaigns. And we've seen people driving admissions at $15,000 before we came in. So you should never be paying that much. If your marketing's decent and your call team is decent, you should never really be paying more than $5,000 to maybe up to $9,000 on the out-of-network side. Again, it depends on what insurances you can take, but you want to think through your numbers in that respect. Now, part of what you want to be looking at in these components from a KPI standpoint is how many of your admissions are coming from a channel like Google Ads. Google Ads is super expensive. It's not overly profitable a lot of the time. It highly varies in terms of how campaigns work month to month. Quarterly, you'll generally see it even out, but month to month, there's a decent amount of volatility. So we always work with our clients to keep their Google Ads admissions under 10% of their total admissions. So if we're working with a provider that has 100 beds, we don't really want more than 10 of their admissions coming from Google Ads for an established center. As a new provider, you've got to spend more because you don't have a reputation, you don't have BD, all these components. But it's really, really important that we keep that under 10% just from a sustainability, a cost standpoint. Your other channels, your business development, your Facebook, your LinkedIn, your email campaigns, your alumni referrals, these are much, much more cost-effective channels. And so when we look at it as an overall breakdown from a KPI standpoint, again, that baseline, everyone's different, but we look at about 70% of admissions coming from community referral sources. That's either business development or alumni. Readmission also gets lumped in with alumni. So we want 70% of our admissions coming from community outreach because generally from a cost per admission standpoint, those range anywhere from $400 to $1,500 in admission, right? So it's a very sustainable cost, even on in-network contracts. However, if you're looking at your digital spend, then when you start factoring in things like Facebook, you start factoring things in like LinkedIn, those costs per admissions are generally lower, right? They're around the $2,500 mark for in-network. And if I say in-network, anytime that if you're an out-of-network provider, you can just double that. You can double it or triple it, right? Because you need at least twice as many inquiries for you to get the individuals that have out-of-network benefits that are interested in coming into a facility and paying that higher cost, usually out of pocket, that comes with OON. So much, much cheaper if you diversify your marketing spend. And then search engine optimization has a very expensive upfront cost. It costs a lot of money to get it going. You know, if you're a new facility with a new website, it's going to take you 12 months to get your SEO running. But it is the cheapest cost per admission from a digital standpoint once it's working. So cost per admissions for SEO are as low as $500. And then usually they're sitting around like the $1,000 or $1,500 mark for the majority of providers. And also remember, I'm talking here a lot about in-network and out-of-network. We also do a lot of Medicaid marketing. Medicaid is completely different, right? Medicaid costs are completely different area. Your Medicaid costs for admissions are anywhere from like $100 to $400 or $500. And we can do a channel breakdown on those, but your cost per call, because there are much more people coming in from the Medicaid side, is just so much cheaper. So and most people will admit, you generally have a 50% conversion rate on Medicaid if they show up and if you're good with your admissions and intake process. So if anyone wants to talk to me or has questions about it, I'm happy to consider Medicaid, but it's a different marketing strategy, same channels, just kind of different metrics, different baselines. And then something else I would mention when you're looking at your leads, VOBs, and admits around conversion rates is that your search engine optimized, or your Google search, right, your organic Google, not the ads, have better conversion rates. So you'll see more commercially insured. The commercially insured are a little bit more discerning. They don't click on the ads as much. They're much more likely to skip the ads. Only about 15% of people that do a search will click on an ad. And of those 15%, 90% of them are Medicaid. Your commercially insured are going to skip the ads. And so you'll see 1 in 4 calls coming from Google organic campaigns to be usually a VOB or commercially insured. So again, that's one of the reasons that SEO delivers such a lower cost per admission, because you get a much higher volume of qualified calls. And then obviously if your call team keeps the same conversion rates, then you're able to convert those patients at a 1 in 8 call ratio. It just ends up being a lot cheaper. And then your overall cost per call from SEO is a lot cheaper too. I mean, you're paying anywhere from $10 to $50 a call most of the time once you've got really good SEO campaigns running. So there's these kind of channel breakdowns, right? And then on top of that, everything blends together. A lot of providers make a mistake where they get too obsessed with their KPIs and they're getting too granular, and they're saying, okay, well, Google Ads is here, Facebook is here, billboards are here, emails are here. That's the wrong way to think about marketing. You can do that to a decent degree with business development, with search engine optimization, with Google Ads. But once you start bringing in display channel marketing and you start pushing out through Facebook or billboards or emails, those do never convert directly from the channel, and you can't track those from call tracking. You'll get calls in, it'll happen, but it's very rare. Most of the time what happens is people see those campaigns and eventually they'll Google search you and call. So you see that coming through your Google search inquiry calls, and you don't see it being tied to or attributed in the marketing language to the specific channels. But what you do see is an overall reduction in the lift and the cost per admission. So as you start running these multi-channel strategies, you'll see your cost per admission drop by 10%, 20%, 30%. And that's because these channels are working together and they're very synergistic in the way that they bring value to you as a provider. The best clients that we have multi-channel strategies. They have the lowest cost per admissions. They have it for years. We see it consistently. We get a lot of pushback because you can't see the cost per call. But within 6 months, once we've got a multi-channel strategy running, and suddenly they see that their overall cost per admission or their blended cost per admission has dropped by 20%, then suddenly they're on board. The challenge is that some providers get antsy, right? And they have a hard time waiting 6 months because they're like, well, I'm spending all this money. Where's the calls? But it works. It works every time. So if you do it right, it's very, very effective. So that's kind of an overall breakdown. I'll pause there. Gives you the 30,000 foot overview of the three legs of the stool and gives you kind of a granular breakdown of some of the marketing channels and how to think through that. I'll take any questions on that. And then if we have questions, I'll answer those and we'll move on to Keith's portion of the presentation. So questions on overall KPIs or marketing and admission KPIs. And you can just put those questions in the chat is the best way to do that. All right. If we've got any questions at the end of the presentation, I'm happy to take those as well. Otherwise, Keith, I'll pass it over to you.
All right, great. Thank you. Yeah, thank you so much. I was just saying that, Nick is an expert in the lowering the cost of admissions, diversifying your channels and all of that wonderful side of the business, which is so important for your facilities to grow. My world is more around integrating data systems and helping create those metrics so that you can monitor and measure all of the key performance indicators that will give you a good benchmark to start with and hopefully understand where you can make those improvements, or when things are going up or down, you're able to react quickly and timely. To Nick's point, on the admission side, you have very important metrics that need to be tracked, and as well as on the revenue cycle management side, which is basically making sure you're getting the reimbursement that you've earned through hopefully providing a wonderful clinical experience. Basically, it breaks down into two portions. We all know that the patient out-of-pockets have increased and will potentially, there's no change in sight for that. So it is important to be able to have good metrics on what is your average patient financial responsibility and how much of that are you collecting. There are companies that specialize in that, such as one of my partners, FinPay. They do an excellent job in that. Other companies focus more on the financial responsibility piece. And of course, you also have that option to perform these in-house as well. And but either way, whether you're doing it in-house or whether you're working with another expert partner, you should always have good metrics, right? So that you can see how well they're doing or how well you're doing in-house. So on the insurance side, which we'll get into some examples here in just a minute. These are really the key KPIs that you should have a good grasp on if you're wanting to ensure that you're collecting, which is typically anything above 90% of insurance financial responsibility is what should be expected. If you're in the mid to high 90s, you're doing excellent. You're always going to have some leakage, some deterioration due to factors that no matter how good you are, you're going to get some denials. However, having good visuals as to how those denials are coming in a timely manner so you can understand what to correct is obviously very important. And then also to be able to appeal those denials and to see what your success rate is on those appeals. Gross and net collections, I think we all kind of know what that is. The part of the net collections aspect is somewhat tricky because you have to be able to know what is your, your actual rate that the insurance is going to allow. If you have contracts, that's great. If you're out of network, it's a little more tricky. But either way, you need to know what is the financial responsibility from the insurance, whether it be a usual and customary rate or whether it be a contractual allowable. And then we can talk more about the whole balance billing aspect of it. That you can reach out to me and we can talk more about that. You always want to know how many days it takes, right, between when you see the patient, when you send the bill out. What is my lag there? Is it a week? Is it 2 weeks? How can you get that shorter? I mean, time value of money is important. Getting the money in the door sooner is always better. And then, of course, what are the number of days to pay? And that varies significantly by insurance company. But it's important to know because you need to know whether there's a claim that's past due or not for each and every insurance that you're working with so that you can address your past due claims timely. Then we get into the AR days or ADO or AR days outstanding. Basically, that's a universally used metric, which is agnostic to your type of business in the sense that you're just trying to see how much receivables have you accumulated in a very simple number. So, for example, if you have $5 million in receivables, but yet you put in $1 million a day, that would be 5 days outstanding. Okay, very simple math. It's universally accepted. You want to keep that under 30 days is top performance. Anyone can have less than 30 days in receivables, then their daily volume is considered top notch. Your percent over 120, you typically want to have that under 15%. Sometimes that's not so easy if you're out of network. And if you have significant private pay, self-pay, sometimes your percentages might go above 15. But anything over 15 is not necessarily bad. It depends on your type of payer mix that you have. So it can be between 15 and 30. How much money do you have past due? We talked about if you don't know your days to pay, then you don't really know what's past due. So if you can identify your days to pay, you can create a KPI where you can track as a percentage what is your past due versus your total receivables. And then, of course, any unbilled claims needs to be tracked, right? So if you're having a problem with getting claims out the door, maybe you're lacking authorizations, maybe there's problematics with the demographics, et cetera, you want to have a pulse on that. And obviously, you want to keep that as low as possible. Typically, that shouldn't be more than 1 or 2%. But if it goes to 5%, you want to know about that pretty quickly. And then, of course, where are you in your forecast? So in other words, if you have good net revenue figures, then you should know what money is expected in the next 15, 30 days. Because your census is known, your charges are known, your days to pay is known, you should be able to have a good idea on what money is going to come in this week, next week, the following week. Okay, let me go here. This is an example of something that Nick was talking about where you want to track, what are your daily volumes, right? How are you going up? Or are you going down? What are your conversion rates? Where are your sources or your channels? How are they performing? This can all lead to ultimately, what is your cost per acquisition per your channel? How much do you spend for each of those different methods? What are the results? How many admissions are you getting? What's the actual revenue per admission per channel? Now you can back into your cost per acquisition and ultimately your revenue per acquisition as well. An example of patient responsibility. Well, first of all, you have to be able to define what is your PFR. So in other words, how is your staff recording the patient responsibility portion in your system? And are they doing that well? Or is that something that you need to improve? Or is there another way that you can back into what should be the patient responsibility portion? Once you've identified that, now you can measure, just like any other KPI, you can measure what is your patient function portion, a patient portion of the responsibility. What is your insurance portion, your calculated insurance value? How much of that are you collecting? Then you can look at it in many different ways, of course. Once you have these baseline methods and formulas, you can now look at it by location, by payer, by all level of care, all different kind of ways. And that really helps you hone in onto where are your performance issues. Are they in the outpatient, inpatient? Is it a certain facility, etc.? Ultimately, measuring your daily NPR or your net, patient responsibility and insurance responsibility, you can see then how much you're collecting from the patient and how much you're leaving on the table. And that can translate into assumptions. If you can improve, I'm giving an example of patient responsibility. If you can improve your patient responsibility, in this case, from 41% to 70%, that can have a very dramatic impact on your EBITDA and your overall profitability. So some people in this industry, specifically historically, have not really focused on that part of the equation. However, as you know, as I mentioned in a slide earlier, if you read that, reimbursements from the insurance are steadily going down, and the patient responsibility is going up to 25% of the total responsibility is from the patient, especially if you're talking out of network. And in network is closer to 20%. Okay, but either way, if you're doing 40%, you get to 50%. What is the impact? 60%. How do you get there? Your KPIs will certainly track as you improve, and then you can create action plans to improve that, or work with a company like FinPay. Now, the insurance side obviously is, a lot of companies are in business because of the complexities, right, of the industry, of the reimbursement process. So many different insurance companies, so many different rules, compliance, coding, billing requirements. It's a mess. However, you need to be able to isolate and compartmentalize all of the different aspects of the insurance revenue so that you can create systems and monitor those systems and measure those systems and improve upon those systems. So on this particular example here, it's just a dashboard that is showing various key elements of what's going on with your insurance revenue. For example, this is a forecast chart. Based upon what I build and when I build it, do you know how much you should collect that week? Have you hit it yet? Was there a delay? So in this case, you can see this particular week, there was a $100,000 shortfall in your expected cash flow from the insurance companies. Well, most CFOs, most owners, when they're $100,000 short in a week, will have a panic attack in some cases, depending on how the cash flow is going overall. But in any case, you want to be able to isolate what is the cause of that cash flow situation. So A, the CFO is happy, the owner is understanding of the situation, your staff is on top of it, you quickly identify where that problem is, and you solve that problem. So now how do you know if it's a problem? Well, in this particular example here, we're showing the payer response dashboard where you're seeing what is the average reimbursement time frame for each of your insurance carriers. You can see it varies widely. Medicaid pays very quickly. UPMC, very slowly. How do you know when you're actually behind? Well, you need to have good metrics in order to analyze that. And if your numbers are going up or down, you expect 36, we're at 48, there's probably a problem going on here. And you can see that it's reflected in the reimbursement. There's $22,000 that are past due for this one payer. They've only met 27% of their expected payments. So these metrics allow your team, whether it be your billing managers, your CFOs, whoever's really looking at these numbers, to quickly isolate where the situation is and be able to explain it, and also be able to find the root cause and a solution. That's ultimately the goal of KPIs, right? Is to solve the problem. You can break down KPIs or your data in, if you define different types of substance abuse, you can then analyze, okay, what is my average length of stay for an alcohol diagnosis? What's my average length of stay for specifically cocaine or opioids, et cetera, et cetera? Again, once you have the KPIs, you have your average length of stay, you're seeing some of your percentages and your volumetrics. You can then start to plan and understand how your clinical mix has an impact on your financial outcomes. And then finally here, I'm just showing you a little bit about how you can measure, your denials by properly categorizing them and tracking them real time. So if you see a big number pop up for no authorizations, you want to be able to drill down into that. Again, get to the root cause. Why am I getting no auths? What payer is it? How do I solve that problem? So these are examples of how data and KPIs can really make sure that you're in touch with what's going on with your business. Now, how do you implement something like this? Try to break it down to 5 simple steps, because many people find ways to do it in not the most efficient way possible. So maybe they're using spreadsheets, maybe they're using pivot tables, maybe they're using Power BI in-house, maybe they're accessing 5 different systems or 3 different systems individually and separately. Very time consuming. The numbers cannot be rolled up together. It can be slow. You can have data issues. So what you want to do first is identify what are those key KPIs that we mentioned, which I'm suggesting a list like this. Some of those might be things that you want to do or can do. Some of them, maybe they're not doable yet, but either way, you want to start with what you have available first, and then have a plan on obtaining how you're going to obtain what you're missing. So how do you do that? Well, you need to either build or partner up with a company like mine, which will help you extract that data into a reliable repository that gets updated daily, if not even more often. You don't really want to do something weekly or monthly, because by the time you get your data, it's going to be stale, right? And once it's stale, it's too late to react. So you want to have real-time pulse, hand on the pulse. The only way to get that is to have real-time data that works together, whether it be coming from Salesforce or Microsoft Dynamics, or your billing platforms, your EMR platform, your call tracker system, Google Analytics. What are your sources of data? How do I get those into one environment so I can create these types of dashboards? Number 3, you need to decide on what is the proper presentation layer. Excel is not it, okay? So there are other options like Power BI. We use QuickSight Analytics from AWS, cloud-based. You don't want to spend a lot of money on licenses. You don't want to spend a lot of money on IT resources. You want to find a solution that's going to be cost-effective and secure and quick. Okay, this is where a lot of people get tripped up. You hire an analyst or you hire a company. They're asking you, well, what do you want? How do you need it? And how do you then validate those KPIs? How do you realize that I'm measuring what I think I'm measuring? So you have to have systems in place where you can back into the number and validate the underlying data fairly quickly. So that's typically what we call a drill down method, right? Where you look at a KPI for a time frame, you want to validate that data, you should be able to drill down and actually see the underlying data that's producing that KPI. Because if you can't really do that, then there's really no way to know whether that number is truly valid. So that's something that is an ongoing process, but once you get through the initial pass, you shouldn't have to worry about it much longer unless you see something, wacky. All right, finally, what is the point of all of this? When you have these KPIs, it requires involvement, right? And you have to involve your team. It's not just a CFO or a CEO looking at these numbers. It's the people who are running the admissions, who are running the billing, who are running the clinical. They need to understand where they stand. So they need to have access to this information as well, and to have goals set around achievement. What is the goal? How are you going to get there? The KPIs are how you measure your progress towards that goal. So those KPIs need to be explained. And so they understand the what goes into those KPIs and why they're important and how it affects their job and their growth within the company. As I mentioned, whether it's Elon Musk, who's your investor, or your marketing and admissions team, your billing team, your clinical team, they all need to know how many days am I authorizing? How many appeals are backed up that are having an impact? Those should all be KPIs that you're measuring. Billing manager, we talked about some of those metrics. Do they understand those KPIs? Are they looking at them? Are they trained? Do they understand the importance of them? They all need to be engaged, all parties. And I like to say you should meet weekly, once a week, touch point, review the KPIs. Are they up, down? Once you have KPIs, you have a structured conversation now, right? You're not just putting an agenda together and saying, this happened, blah, blah, blah. Okay, let's start with the KPIs. Are the KPIs good? Are they getting better? Are they getting worse? Okay, now tell me why and what your plan is. So in summary, any company in this day and age that does not have proper, valid indicators of the core aspects of their business is going to be at a disadvantage. It's a competitive field. You have limited resources. You have limited staff. You want to make sure you're all on the same page and that you're focusing as a team and that you're all engaged by using these KPIs as a way to measure your performance. So that's all I have. And if there's any questions, I'm also available to answer those along with Nick.
Well, we're seeing any questions appear in the chat box. There's two comments I want to follow up on what Keith said. So troubleshooting is a critical value add to your KPIs, right? And so to give a really concrete example, let's say that your cost per admission is really high last month. Well, why is it high, right? Is it your call center? Are they not converting well? Is it your business development team not bringing in enough qualified referrals? Is it your marketing channels? What marketing channels? Is it Google Ads? Is there something going on with Facebook? Is there something going on with your email campaigns? Is the landing page converting appropriately? Are the ads converting appropriately? What's your cost per click? What's your cost per call? Right? There is, 20 to 30 things that could be out of whack that's driving your cost per admission higher. And the only way to figure that out is to drill down into the specific department and then the specific channels. So it's really, really important to understand what KPIs affect the ultimate KPI that you're looking at. So you just kind of go down the line. And then the other thing I'd comment on there is also around the window. So, Keith mentioned a week, which makes sense for some KPIs. On the marketing front, you have to look at a 30-day window. And we have clients that are spending $500,000 a month on their marketing campaigns, right? So that's $12,000, $13,000 a day running through various channels. So people can get antsy and they can start saying, admissions were high yesterday or admissions were high 2 days ago as a cost. It's meaningless. It's just noise in the data. There is changes in search behavior, changes in search volume, changes in the way that people interact on a day-to-day basis and a week-to-week basis. So you also have to understand your data window. To really give an easy example of this is I'm from Wisconsin, and in northern Wisconsin, it's really cold and it's winter from basically November to April. Well, if I took house sale numbers for real estate agents and I ran a 6-month window from November to April, nobody sells homes in Wisconsin in the winter. There's just very, very little people listing, very, very few people buying. So that even I had 6 months of data, it's actually irrelevant data. It's just noise because almost all home sales occur between May and October. So you have to look at your data windows. And so from a marketing standpoint, if you're looking at something like Google Ads, it's a 30-day window. If you're trying to change your Google Ads campaigns significantly every week, now you optimize them every day. But in terms of like an overall CPA, you're looking at those at most biweekly, and really you're looking at it monthly. When you're looking at other channels like SEO is a 3-month lead time to really see changes start to have an impact and have an effect. Same thing with your push campaigns, billboards, Facebook. Those tend to be 3 to 6 month windows. And so if you're evaluating and looking at your final attribution costs and saying, hey, my CPA is high yesterday or last week, it's just noise. It's just meaningless. You have to be strategic in the way that you look at your campaign performance and your metrics, and you have to understand your data windows. So I just wanted to put that in there because it's really important. It's something that a lot of providers misunderstand, and they make bad decisions because of it. They'll say, okay, well, our CPA is way up last week. Something's wrong. We got to fix something. They'll make a million changes. It's all noise. It's all meaningless changes. They're just spinning their wheels. They're just wasting time and effort, and then they're messing up the data. So because they made all these changes, there's no consistency, and now we can't actually see what impact that the changes have because they're changing it too much. So just kind of want to add that component in there. Did anyone have any questions? I'm not seeing any in the chat window. Well, all right, Keith, anything to add? Otherwise, I think we'll just wrap her up.
No, I know there's a few folks that are at the conference, but they'll be chiming in later.
Yeah. All right. Well, appreciate everyone that was able to make it. And if you have any questions, you've got our contact information in there, so feel free to reach out.
Yeah. Thanks a lot, Nick. I also learned a lot.
Thanks. Have a good one too.
Thank you so much. Bye, everyone.